So Gagan is going to tell us about one of the rare situations, not very common, optic disc maculopathy. There are a lot of controversies surrounding optic disc maculopathy. Some people leave it alone depending on the vision. Some people do only, hyaloid. Some people do ILM. Some people plug it inside. There are a lot of, varieties available. So Gagan will tell us how he manages.
So good afternoon, everybody.
Gagan, everybody knows, is from Shroff, Delhi, and a prolific surgeon again.
So I think optic disc pith, I think we all know has an incidence of 1 in 10,000. And can I have the control here, please? Yeah, so optic disc maculopathy basically is a serous detachment which is associated with optic disc pit in almost 50% of the cases. And this is how a typical NSD in an optic disc pit would look like, with a schisis, with NSD, and as well as an outer lamellar hole. So there, as Sir rightly said, there are so many techniques which have been defined, but we'll be talking about human amniotic membrane grafting. And so this challenge kind of came up when we went through this paper by Rizzo, where he kind of described 3 eyes of 3 patients where he used amniotic membrane graft. And then we had our own challenges while using amniotic membrane grafts. So first was the visualization of the graft, because it's very transparent and very thin. Second is making the right cut, because again it kind of keeps rolling over. So we kind of devised our own strategy, which was basically to stain first with brilliant blue, and which kind of makes it a little less transparent. Then sizing was basically the radial diameter of the pit. And then was making the graft, which was basically by using dermal trephines. These are very cheap dermal trephines which you get in various sizes. So we kind of published this in JVRD and as a triple S technique. So coming to a surgical video, for an optic disc pit, you would induce a PVD and then do a ILM staining. It is very important that when you do an ILM peel in these cases, be very careful not to deroof the macula. I think do a macular sparing peel. And in these cases, what I prefer is to leave the nasal ILM for the end, but I'll tell you for what. And then after the ILM peel is completed, then you can shorten these leaves and then remove the graft from the paper, and then bimanually place the graft over the optic disc pit. It is imperative that you very carefully and gently kind of push this into place. You could use either a nitinol loop and a blunt tano. And then finally you take this ILM flap just to secure the, keep the graft in place. And finally fluid air exchange is done, and the case is closed. So coming to a representative cases, this was the first case, which was a 12-year-old female, and she underwent an ILM peeling with a grafting. And finally, if you see, this was the first wow result that I got in the first case, and that I was very encouraged to do this, and where there was complete resolution of the NSD within 3 months. And this case has now been followed up for almost 3 years now, 4 years, and it's doing well. This was the second case of a 25-year-old female again. She underwent a grafting only once the NSD came. So I'll come back to that point, and her vision dropped. And this again, she improved very well, and the graft is still in place. If you do a Swepsource OCT, you can see that the graft is still in place and the NSD goes away. The schisis still stays, and this is also another point that we can discuss later. This is the third case. Not all cases do the same. So this case again, if you see that within 6 weeks, I kind of realized that the graft is a little up. And then finally at 2 months, the NSD had reduced, the vision had improved a little bit, and there we found the graft which was lying on the nasal edge. So in 5 cases of 5 patients, we had a female preponderance with more so in the left eye, and all patients had retinoschisis as well as CME was seen in 2 eyes. The mean duration was around 5 to 6 months, and the horizontal diameter was around 700 microns. There was a drastic improvement in the visual acuity in most of the cases that we did, and also in the central foveal thickness. The last follow-up was around 11 months, and the AMG was in situ in 80% of the cases except the one case which was there, and there was complete resolution was seen in 60% of cases. So at the same time, Caprossi came out with their 1-year data from the paper which they had published earlier, and the results was almost the same, with similar kind of outcomes, with 80% of the eyes showing complete resolution of this. So I think with various techniques being described, I think ham grafting seems to be quite promising, and though I'm not against any of the other techniques and I've tried all of them, with varied results. But at least as of now, I think HAM seems to be quite promising. Thank you.
Very nice videos, Gagan. Excellent results also. Although optic disc pit is not so common that you can have tens of cases unless you do that. But one thing is that a lot of people refer as CSR. It's not CSR. It is a Scheisses, and it is what is that Cronenberg syndrome. It is known as, and but varieties of techniques. I would ask you, see what part that HMA, amniotic membrane, because you have put both the things covered with initially HAM and then put ILM also. People do only ILM also. So
yeah, but that they do, what they do is basically stuffing. I'm not stuffing it. So I'm not even touching that thing. So it's just the nasal thing is there so that it does not slip that side. That's the only thing. So there is a case which is not there in this series, but the pit is quite central. So in that I have not put an ILM.
Have you done
flap.
anything HAM without ILM being placed over it?
HAM with ILM? Yeah. That is what I'm saying. So in cases, there is a case where it was more of a centralized pit. So I did not put a flap. So it's not that, so ILM, I've done an ILM peel, just a peel. I've done an ILM tuck. I've done an active extrusion suction, and there have been varied results with all. And but as of now, this grafting is helping a lot. So now this series has gone up to almost 9 cases now, 9 or 10 cases now. And I think the results are quite promising, except for that one case where I could see the graft not being there. And the procedure was the same even in that person. So if you see the OCTs, the ILM is still there, but the graft is not there. So maybe it's working much better than other. And I think scleral graft has also been kind of documented by Dr. Naresh. So
that paper won a Rangachari award. From Coimbatore, it was described. You can put a scleral tissue over it also. So all sorts of funny tissues have been placed just to plug that opening, because there is a communication between that pit and the retina. You can document on OCT, but very nice results you have got. Any comment?
Any experience it after FG, after fluid exchange?
Fluid exchange, slipping. Yeah, that's the
no,
most.
It doesn't. It usually would not slip, because usually these pits are little curved. So when you put it in and if snugly there, then it usually would not.
I'm asking any experience. Have you tried doing a air exchange first and then injecting?
You could do that, but then the problem would be putting the flap on top. That's the only thing. So usually in macular holes, if I use amniotic membrane grafting even for macular holes, overlay and as well as an underlay. So we do it with post FGE only, so not pre. In these cases, what I basically do is put off an active suction if you have an active machine, and the active infusion, you put it off so that it does not swirl inside the eye. But other than that,
but in any case, all these patients, you have to slightly tuck it.
Yeah, slightly tuck
Without
has to be
it
there.
Will not.
No,
without tucking it will slip.
And
so you can't just place it there and hope that it will serve the purpose.
So the basic thing is,
tucked.
so you like in an overlay technique, people have, in an overlay technique of macular holes, people have used enormous size of grafts, which I don't agree to, but they have. So, but in this, it is very important that you use the right size of graft. So in most of these cases, I've used a 1 mm Trefine. So if you use that, it kind of nicely tucks into place. So you can use it.
Can you elaborate how do you measure? Because that is, I think,
radial diameter. The maximum radial diameter on a swept source OCT is what I measure.
Maximal radial diameter.
Radial diameter.
And same size you punch.
Same size I punch.
It is oversized नहीं होना चाहिए.
Oversized
में तो मुश्किल हो जाए.
Yeah.
Maybe undersize may still work.
Still work, yeah.
Yeah. Any question? Yes.
Sir, we had one case of optic disc pit because of non-availability of amniotic membrane around our setting. We used a scleral graft. So, sir, from where do you source these amniotic membrane?
It is basically a cryopreserved graft. There are various companies which make it.
It's commercially available now.
It is commercially available. So this one is from Aurangabad. They ship it all across India.
Aurangabad.
The one point that I want to make in optic disc pit, which I showed in the second case. So this second case had a huge schisis, but the vision was always 6x6 N5. So it is very important that don't intervene too early. That is very important. So only when that patient developed an NSD and the fluid and the vision came down is the right time to operate. So just because good results are there does not mean that early intervention is required. That I would not agree to. Yeah.
Because these are not so straightforward cases that only because of Scheisses you will go inside again.
Yeah.
So let's hear now.
Some people have also tried a peripapillary laser low
that is thing of the past now.
Okay.
Because so I know when we were senior residents at RP Center, I'm talking of 35 years back, 40 years back, I have myself have done a couple of these peripapial laser. At that time, in any case, ये इतना सारा होता नहीं था. We didn't used to do all these things. But there was one paper, Gagan, I was reading. He says combo of everything is important.
Yeah.
You see this mechanical barrier, what he's talking, even ILM
Flap,
full threaded
and
pin
pin.
and put. He says the results get improved in case you do all the 5 things. But that is an overkill, I think. That's an overkill because you are destroying the papillary
Papillary
bundle
barrier.
also.
Yeah.
That's the 80% of fibers go from there. Chal, thanks Gagan
you.
for excellent